Everybody, we're going to get started now. Today I have the pleasure of introducing Dr. Mollie Biewald with us. She's an assistant professor in our Department of Palliative and Geriatric Medicine. She did her training here at Mount Sinai as an internal medicine resident, continued on here for her palliative medicine fellowship, and is now also serving as the associate program director in the palliative fellowship. So she's going to be speaking to us today on pain management, and we welcome Dr. Mollie Biewald.
Thank you so much. It's so nice to be here. I was just reminiscing with Trini that she was my first attending as an intern a couple years back. So I'm going to talk about managing pain in the hospital for patients with serious illness, which is something that I would imagine many of you do every day, as I do. What I'm going to cover today is first selection of opioids based on the patient in front of you. We're going to do some conversions between opioids using an equianalgesic table. And if anyone doesn't have a pain card, they're at the end of the table. Could you pass them around? We will talk a bit about using fentanyl patches, which I think are a great method of pain control, but I see sort of messed up all the time in the hospital, and I would guess that many of you see problems with them as well. We will talk about which patients might be best for PCAs, and then we'll talk about appropriate use of naloxone. So in terms of the outline, we will cover those things in basically that order. So first we'll do a crash course in opioids for pain, talk about fentanyl patches, PCAs, naloxone, and if we have time, we can go through some bonus questions or talk about some tricky cases that you've had recently. So first of all, anybody recognize this plant? This is Papaver somniferum, the opium poppy. And I just want to start with a little bit of language, because this gets used in a variety of different ways that drive me crazy frequently. And I think it's important to be sort of exact in what we talk about. So people often mix up opiates and opioids. The word opiate describes the alkaloid compound that's naturally found in the opium poppy. And that really just includes morphine and codeine, the naturally occurring opiates. Opioid is the more general term that I prefer to use because it includes all of the drugs that we have that have morphine-like action. So the newer medications like hydromorphone, fentanyl, methadone that you probably see used every day in the hospital are opioids in the umbrella term. And then narcotic is a term that is really a law enforcement term. And it has a very vague definition. It's a variety of substances that dull or distort the senses, and it really doesn't have a place sort of in a medical context. But I sometimes see it used in Epic, and it drives me crazy. So opioid is the term I like to use. And I know lots of people in the room have been here for a long time and have a great sense of when to call palliative care versus the pain service. Is anybody here newish? Been here less than a year, maybe? And did anybody train in a place where there wasn't a big palliative care presence? So this may be different in different hospitals. Basically, I just want to make the distinction between when to call us palliative care versus when to call the pain service. So palliative care is specialized medical care for patients with serious illness, and we do three main things. So we do symptom management, including pain, which we're talking about today. We also manage nausea, anorexia, constipation, fatigue, a variety of symptoms. We help out patients, hospitalists, teams with discussions of goals of care. And we can provide an extra layer of support in the setting of serious illness for patients and families. As you might have noticed, we travel with a huge interdisciplinary team. So we've got chaplains, massage and yoga therapy, doulas, sometimes pet therapy, social worker, a variety of people. And this is Josh. Does anybody know Josh Lassane? So he is the triage nurse who you will reach if you page 9399. If anybody here is on the long stay committee, any participants, you might know him from that, from there. And then the anesthesia pain service is really more appropriate for patients who have post-operative pain. So they really manage the first couple days after a surgery. More appropriate to call them if a patient is known to the pain service, inpatient or outpatient. If you think a patient might benefit from a nerve block or another pain procedure, they really do those and we don't. And then for pain that's not in the setting of serious illness, because that's not something we're trained to manage. Any questions about that? So I want to start with a crash course in opioids for pain. And does everyone now have a pain card? These are hot off the press thanks to Susie Goldhirsch, who's here from Palliative Care. And that is the items that all of the Palliative Care fellows carry around in their pockets. And I think this is a well-timed talk because in the next couple of weeks, Lindsay Dow, who's another Palliative Care attending, is going to be teaching pain management to all of the interns and residents. So I want to basically give you a heads up on what the house staff are going to be learning. And a lot of this is sort of more art than science of medicine. A lot of it is kind of how we practice here at Mount Sinai, and maybe a little bit different than wherever you trained. So I'm just going to review how we teach it here. So if you pick up your pain card and turn to the back of it, this is table 4, which is an opioid equianalgesic table. It's on the back, so it's easy to flip to. And for most people, this is the only table that you really will need to use. So basically, the purpose of this table is to show you all of the opioids that patients might come into the hospital on, over on the left. So morphine, long-acting morphine, and so on. And all of the numbers here on the table provide an equivalent amount of anesthesia, at least in theory, to a patient. So 10 milligrams of IV morphine is equivalent to 30 milligrams of PO morphine, which is equivalent to 1.5 milligrams of IV Biewald. And in terms of the opioids listed here, there are some that we actually use in practice and some that I rarely or never prescribe. So I would guess that you probably see the same ones that I see in practice. So morphine and long-acting morphine, we see those all the time, right? Oxycodone, long-acting oxycodone, maybe a little bit less often, but still you might see a lot of patients coming into the ER on these medications. Hydromorphone or Dilaudid, I feel like at Mount Sinai we use this for 95% of patients. And then fentanyl you'll see often in an ICU context. So the ICUs love fentanyl because it's shorter acting than the other opioids, but it has a lot of volume. So for somebody that's volume overloaded, you really want to stay away from fentanyl. The other opioids here, hydrocodone or Vicodin, has anyone prescribed that recently? We do have it on formulary. And codeine. So hydrocodone and codeine are both weak opioids, which in practice means that they're not very effective and they come with a lot of side effects. So it's really almost never useful to use a bigger dose of one of these over a smaller dose of one of the strong opioids. And then methadone is a great medication because it has nociceptive and neuropathic effects on pain, but the conversion is very complicated. You'll see that there are no numbers listed here on the table. It's because it's very complicated math to convert. The next thing I want to point out on the card is that we've got IV medications here and PO medications here. So you can probably see people come in all the time to the ED who are on a PO home regimen or NPO for some reason, or we start a patient on an IV regimen in the hospital and we want to discharge them. So this table is very helpful for doing simple conversions back and forth between IV and PO. And then the last column is duration of effect. And if you take a look at this, you'll see there's really only 3 different options here. So there's 4 hours, 12 hours, and then 1 to 2 hours. So all of the short-acting or immediate release opioids, at least in theory, for most people, last about 4 hours. Most of the long-acting opioids, and we'll talk more about this later, at least in theory, last for 12 hours. And then fentanyl, like I mentioned, is sort of faster on and faster off. It's 1 to 2 hours. So I want to start with a case. Does anybody recognize this lady? Any fans? No? No one? Come on. So Ms. Crawley is a 78-year-old woman with a past medical history significant for hypertension, breast cancer status post bilateral mastectomy, and chemotherapy, which she completed 3 months ago, who comes to the ER with right arm pain. She says her pain is 8 out of 10 in severity, so it's a severe pain. It is sharp and stabbing. It's in her mid to right upper arm and does not radiate. It's constant, gets worse with movement and lifting. She took 1 gram of Tylenol and it brought her pain from an 8 down to a 7, so not terribly effective. And she's no longer able to cook, clean, or write. The ER does a BMP and it's unremarkable. So for this lady with severe pain in the setting of cancer, do we want to give her 30 milligrams of PO morphine, 800 milligrams of ibuprofen, 0.2 milligrams of IV hydromorphone, 2 milligrams of IV morphine, or put her on a gram of Tylenol around the clock? Any takers? Does anybody like option A? Okay, what about B? Maybe? C? It's Mount Sinai? What about D? Okay, and what about E? Yeah, so I think option C would be a fine option, but I think option D is even better. So 2 milligrams of IV morphine for this patient who has no contraindication to morphine and has severe pain in the setting of cancer and is in the ER where we can give her an IV dose. This is what I would start with. In terms of starting doses for opioid naive patients, and this may all be a quick review, the lowest doses that I usually give to patients are morphine immediate release 7.5 milligrams PO. So morphine comes in a 15 milligram tablet, and the smallest that we can go is cutting that tablet, which is scored in half. So it's not really possible to give a lower dose of morphine. 2 milligrams IV is usually the lowest dose that's effective for someone. You can give 1 milligram IV, which I do sometimes if someone is 100 years old, but otherwise really not helpful. Oxycodone comes in 5 milligram tabs. That's reasonable to start. And then we do lots of hydromorphone here at Mount Sinai, so probably everyone is very comfortable with this. Dilaudid comes in a 2 milligram tablet, which is very small and is not scored. So some nursing units will cut it in half for you and some will not. 2 is really the smallest dose that you can reliably give to patients. And then 0.2 milligrams IV. Fentanyl, I'll usually start with 25 micrograms. And for older people or people with kidney or liver disease, I usually will use these same doses, but just make the dosing interval longer. And then if you have a patient who is really, really opioid sensitive, or you're otherwise very concerned the family really doesn't want to sedate them or whatever, you could consider giving liquid morphine or liquid oxycodone to give an even smaller dose accurately. Liquid morphine you can get in the hospital. Oxycodone is sort of hit or miss. And then at the bottom of table 4, I just want to point out it lists the available strengths of the different opioids. So if you need a reminder of what I just said, you can see that, for instance, morphine immediate release comes in 15 milligram tablets, which you can cut in half, and so on. So we're going to start Ms. Crawley on PRN IV morphine. How often do we want to put this dose in for her? Anybody like a Q1 hour PRN? Any Q2s? Q3? Q4? So for this lady with normal renal function who's in her 70s, I think it's reasonable to give Q1 hour PRN. I see these doses written in the hospital in a variety of Q random number of hours. And the reason for this really depends on pharmacokinetics of opioids. So when is it safe to give a second dose of an IV opioid? You want to wait until you've reached peak analgesia because you want to see if giving another dose is actually warranted. And you want to make sure that you've reached peak effect of sedation and respiratory depression, which are probably the side effects that you're most worried about. And when this happens really depends on which medication you're using and what the dose is, what the route is. So here we have time on the x-axis and plasma concentration of an opioid on the y-axis. And this blue line is supposed to indicate after giving a PO medication, we see onset of analgesic effect at about 30 minutes and peak effect both of analgesia and of sedation and respiratory depression, usually by about 60 minutes. The pink line represents a subcutaneous medication. So it's a bit faster than PO, peak onset by 15 minutes and peak by 30 minutes. And then IV medications sort of obviously work the fastest. Usually we see some onset by 5 minutes and then peak effect both of analgesia and of the concerning side effects by 10 or 15 minutes. And this is really the reason that you can give another dose so soon afterwards. So in the setting of a pain crisis where somebody is having really, really severe pain that's not resolving quickly with a dose of an opioid, we'll sometimes stand at the bedside and give a dose and double it every 10 minutes. It's not unusual to do. And that's safe to do because of what I just showed you. So theoretically, you could write your opioid PRN for an IV Q10 minutes PRN. I don't think the nurses would be very happy about that. And for most patients, it's really not necessary. And if someone is in that severe pain, you probably should start a PCA or some other method. So we usually write our breakthroughs Q1 hour PRN. And then for outpatient use, I'll usually switch to Q4 hours PRN because no insurance company is going to cover more pills than that. It's impossible to prescribe more than that. And once a patient is out of the hospital, it's really a question of safety in an unmonitored setting. So let's get back to our lady for a minute. We prescribe her 2 milligrams of IV morphine, Q1 hour PRN, and 2 days later, she says her pain is well controlled, but she's frustrated by having to ask for a dose every 4 hours. Every dose that she takes is bringing her pain down from an 8 to a 2, so it's pretty effective for her, and she's now tolerating PO. Any thoughts on what you want to do for her now? What? Yeah, let's put her on a long-acting. Love it. Does everyone know Liz? Do you guys want to describe what just started yesterday quickly?
We'll go to like the staff meetings and that's officially but
Okay.
Liz is up and running. She has joined. She started yesterday with me, so we'll be more available and be more involved in this.
We're very excited about this. Thank you. So for a patient who's having episodic pain, we give PRNs as needed and reassess. But for a patient like this patient who's having constant around-the-clock pain, it makes sense to dose her opioids around the clock with extra breakthrough doses because we want to control her pain around the clock. We give these medications to maintain steady state of the opioid, which for immediate release medications, like the short-acting morphine she's been getting, it lasts about 4 hours, so we dose it every 4 hours, makes sense. And then long-acting medications, like you mentioned, Liz, usually last about 12 hours. So we usually dose them according to whatever the formulation is, and we'll talk more about this. And then you could also consider putting a patient on a continuous infusion. Once we start a continuous or long-acting regimen, we usually add on a new PRN dose for breakthrough pain that the patient might have. And for this, we always use short-acting medications, although patients sometimes get confused about this and take the wrong medication. And the PRN should be about 10% of your new total daily dose. And we'll do some of that math. So in terms of duration of acting, there are a whole bunch of long-acting medications that we'll talk about. These are also called sometimes sustained or extended release. And I really think of them when I see a patient who's using a short-acting medication, usually 4 or more times a day. And for someone who has pretty stable pain that's reasonably well controlled on the regimen they're on. If somebody is having wild fluctuations in pain and you haven't really gotten it under control yet, you probably want to do a little better job controlling things with short-acting medications before you switch to a long-acting regimen. And the purpose of the long-acting med is mainly for convenience. It doesn't really do anything different than the short-acting meds do. But if someone's going home, you don't want them waking up every 4 hours to have to take a pill. So much more convenient for patients to take a pill twice a day. So long-acting opioids that exist are morphine extended release, which is dosed every 12 hours, and is also known as MS-Contin. And this may be incredibly obvious to everyone in the room, but halfway through fellowship, I realized that the Contin is for continuous or continuously acting, and that is how we remember that it's MS-Contin. Oxycodone extended release, or OxyContin, which I have a few things to say about later. It's not my favorite drug. Oxymorphone extended release, or Opana. Has anyone seen anybody on this recently? So the extended release formulation got pulled from the market in July because it has incredibly high rates of IV abuse. And I had a fellow last year from West Virginia who said that patients were sharing on Pinterest boards how to crush and inject Opana. Like apparently this was how it was getting around. That was fascinating. But we can no longer get this formulation. There is the fentanyl patch, which is dosed every 72 hours, which is really nice in that patients don't have to take PO, and they don't have to change it for 3 days. We'll talk more about that in a bit. And then methadone, when we dose it for pain purposes, is dosed every 8 hours. For most people, that's how long the analgesic effect lasts. And one interesting thing about fentanyl is that it's the only long-acting medication that you can crush and put through a peg. The long-acting ability of it is inherent in the medication. None of the other ones should be crushed. Can anyone identify what this item is? Took me a little while. It's promotional, and I think it's made out of paper. Any guesses? It's a sun shield for the front window of a car.
We don't drive.
Yeah, no one here drives. I don't drive. So when a patient comes in and asks you for OxyContin, does that make anyone feel uncomfortable? Does anyone have a weird feeling about OxyContin? So there's tons of articles in the news right now about all of the sketchy things that were going on with marketing to doctors. And I really try to stay away from OxyContin if I can, for a couple of reasons. One is that the street value is much higher than the other medications. So it's about $60 to $80 for a pill that's equivalent to a dilaudid pill that's about $5. So patients really want this for whatever reason. In terms of why some patients really want this, there are some studies that are coming out recently. So basically, a long-acting medication should provide slow and steady pain relief over the course of about 12 hours. And the way that OxyContin is formulated, it gives people this euphoric burst early on after taking it that makes some people feel high. And then there are a couple studies coming out recently that it actually, for many patients, has end-of-dose failure after about 8 hours. So it was formulated to wear off early so that people have to take more pills of it. Some of this is sort of rumor and hearsay still, but I think there's enough mounting evidence that I really try to stay away from this. The one time that I will give it is a safer medication to give in the setting of renal or liver failure. So for somebody who can't take methadone or fentanyl and needs a long-acting medication, that's when I'll prescribe this. So for our, yes. Depends on the patient. So I usually will start Q12, and then if someone is describing end-of-dose failure, so like after 8 hours I am in terrible pain again, then we can get prior auth to do it more often. But I find that much more commonly than with any other medication. So for our patient, let's start her on a long-acting regimen. So get out your pain cards, please. So there are basically 3 steps. We're first going to calculate her 24-hour morphine usage. So we've been giving her 2 milligrams of IV morphine every 4 hours. So that comes out to 6 doses a day. 2 times 6 is 12 milligrams of IV morphine in 24 hours. We want to convert her to PO. So what's the conversion between PO and IV? 1 to 3. So we're going to take that 12 milligrams of IV morphine. And IV is 3 times more potent. So we will multiply it by 3 to get her new PO regimen. And that comes out to 36 milligrams of PO morphine. And then we want to convert that to a long-acting regimen. So MS-Contin are usually dosed every 12 hours. So we're going to take this new 24-hour dose and just divide by 2 for her new Q12-hour regimen. So 36 divided by 2 comes out to 18 milligrams of PO morphine. Does MS-Contin come in 18 milligram tablets? If you look to the bottom of your card, what sizes do we have? Yeah, so we just go with whatever the closest available dose is. So we'll convert that 18 to the 15, and we'll prescribe her MS-Contin 15 milligrams PO every 12 hours. And that came out pretty close. So we have her on this new regimen, and we need to give her a new PRN medication. So she is now getting, or still getting, 30 milligrams of PO morphine in 24 hours. And like I mentioned, the PRN is usually about 10% of the total daily dose. So 10% of 30 milligrams comes out to 3 milligrams. Can we give her 3 milligrams of PO morphine? Is that physically possible? Right, so we're going to go with whatever the closest available dose is. And the smallest available dose is more than twice that, but still a very small dose of morphine. So we'll go with 7.5 milligrams PRN. And while she's still in the hospital, I would give her that PRN either Q1 or Q2 hours. But when she's discharged, like I mentioned, no more often than Q4 hours PRN. Any questions about that? I know it's a lot of math on a screen. I apologize for that. So I want to talk about a couple of the common side effects that I'm sure everyone in the room has seen patients on. So constipation is by far the most common opioid-induced side effect. And it sometimes feels like half of the NP-ONC service here is patients who were sent home on an opioid without a bowel regimen and come back because they have really severe constipation. This is a side effect for which tolerance never develops. So as long as a patient is on an opioid, they should be on a bowel regimen. And we see a lot of older patients who are already at higher risk of constipation, and it is multiplied many times when placed on an opioid. In terms of treatment, the issue with opioid-induced constipation is that the opioid is acting on the mu receptors in the gut and slowing transit. So it makes a lot of sense to me to use a stimulant laxative to speed up transit. So Senna is usually what I'll start with, and I'll usually give a PRN osmotic like Miralax. And then if a patient hasn't moved their bowels for about 3 days, we'll usually give a Dulcolax suppository then. This is kind of my formula for almost every patient on an opioid. Can anybody identify any of the people in this picture? Steve, who's Steve? You know where he went? He did, and he's now at University of Vermont running their palliative care fellowship. Anybody else in the picture stand out? Does anyone know who this horse is? It has its name on it. So the year that I was a fellow and we were all looking for jobs in New York, there were a total of 2 positions available in New York. And one of my co-fellows arranged to have this therapy pony come and visit a dying equestrian in the hospital. And the chair of our department would not stop talking about how amazing it was that this pony came to visit. And we were all going to kill her. That's a separate story. But I bring up Steve Burns because he was kind of obsessed with opioid-induced constipation. And he was really obsessed with this one study that he would cite in like every note that I would write, he would co-sign with a citation of this article. And it drove me a little crazy as a fellow, but now it's stuck in my mind forever. So basically, there are not a lot of studies that are well done in palliative medicine. This one was reasonably well done, so he sort of latched onto it. It was in 2013 in Journal of Palliative Care and Symptom Management, and they randomized a group of hospice patients to Senna plus Docusate versus Senna plus placebo for opioid-induced constipation. And basically they found that giving Docusate when you're already giving Senna is not better. It's not helping anyone. And it actually made it a little bit harder for people to have a bowel movement. So he would go around the hospital stopping Docusate on every patient. It may be helpful in some patients with other forms of constipation, but for opioid-induced constipation, there's really no role for using a stool softener or Docusate. And anybody give methyl naltrexone? I think it's kind of an amazing and beautiful drug in its mechanism. I sort of love it. So like I said, most of opioid-induced constipation is from agonism of mu receptors in the gut, and methyl naltrexone is just a methylated version of naltrexone, the opioid antagonist, and it can't cross the blood-brain barrier. So it just antagonizes in the gut and allows people to have a bowel movement, but doesn't reverse their analgesia. So it's just kind of cool how it works. About half of patients in one study with severe opioid-induced constipation who had failed other regimens had a bowel movement within 4 hours. The reasons that we don't use it for everyone all of the time are that it costs $55 a dose and it's an injection. You want to avoid it in patients with a bowel obstruction. And here in this hospital, it has to be a pain or palliative MD who orders it, but you could just call us. Happy to order it. Other side effects. Anyone seen nausea from an opioid recently? It's pretty common. It happens in about a quarter of patients that you start on an opioid. Most patients develop tolerance to this within about a week and will generally just treat through with an antiemetic. There's not a lot of studies about this, but there was one small study showing that Zofran was more effective than Reglan, so I'll usually start with that. And then sedation is something that lots of patients and families worry about. Most people get tolerant to that within about 1 to 3 days, and I'll usually counsel them that you might feel sleepy for the first couple of days that we start this, but that probably will get better. And then if you see someone having myoclonus, respiratory depression, urinary retention, or delirium, those are reasons to rotate to a new opioid. So let's get back to our lady one more time. So she comes back to the ER after you sent her home on her nice new long-acting regimen. She is lethargic. She has a CT done that doesn't show anything, but her CT chest, abdomen, pelvis unfortunately shows new mets to the lungs, and her BMP shows that her creatinine has bumped up to 3 from a baseline of 0.65. So we have this lady on morphine. What do we want to do with her? Do we want to continue her morphine in the setting of renal failure? This is the Mount Sinai Hospital. No, let's stop that. So if you turn to table 3 of your opioid card, this gives guidelines for opioids in kidney and liver disease. And what I want to point out here is that morphine should not be used for a GFR less than 30 or for dialysis patients, and should also not be used in the setting of severe liver disease, which describes many people here. Oxycodone and hydromorphone are both okay to use for people with kidney or liver disease. They're not the best option, but we can use them safely if we decrease dose and frequency. And then fentanyl and methadone are really the preferred agents. So fentanyl either in a patch form or an IV. And then methadone, but as you can see, because it's written multiple times along the bottom here, don't try to do this conversion on your own. Please call us. We're happy to help you. It's very complicated. So in terms of choice of opioid, I think about what has the patient been on before that's been effective for them? Are their kidneys and their liver working? What do we have on formulary, and what can they actually get through their insurance? What's the cost? And for most people, morphine is appropriate if there's no contraindication. So for this patient who's now in renal failure, I would like to convert her to another medication. And this being Mount Sinai, let's go with hydromorphone. So to do an opioid rotation, we're going to first add up 24-hour usage of all of her current opioids. We're going to calculate a new 24-hour dose of a different medication using our chart. And then if she's someone who's tolerant to the original opioid and her pain is well controlled, we're going to cut the new dose by 50% for incomplete cross tolerance, which is basically kind of a hand-wavy, no one really understands it, way to describe this phenomenon that if someone has been on an opioid for a couple of weeks and you start them on a different one, they usually get a much stronger response to the new opioid. So in this case, her body's probably somewhat tolerant to morphine, but we're going to start hydromorphone that's new to her system. So first, we will add up her 24-hour opioid usage. So we have her on this regimen of MS Contin twice a day. And for simplicity's sake, we're not going to figure in PRNs here. So she's getting 30 milligrams of PL morphine. We're going to convert to dilaudid. And the way that we do that is by looking at table 4 on the back. So we're going to take her 30 milligrams of morphine and multiply it by the proportion of the opioid we want to use over the one that we are converting out of. So if you look at the table, 1.5 milligrams of IV dilaudid is equivalent or equianalgesic to 30 milligrams of PO morphine. So just multiply by that proportion, and that gives us 1.5 milligrams of IV dilaudid. Like I said, she's been on morphine for a little while, so we're going to cut by 50% to account for incomplete cross tolerance. So our new 24-hour dose is 0.75. And then we're going to figure out how to dose this medication in a new schedule. So this is her 24-hour dose. We're going to divide it by 6 for Q4-hour dosing of her new opioid. And then this comes out to 0.125 milligrams of IV dilaudid, which is smaller than the smallest dose that we can give. So I'm just going to give her the smallest available dose, which is 0.2 milligrams. And then in the setting of renal failure, I'm going to be conservative, and I'm going to dose this every 6 hours scheduled. Any questions about that? It takes a bit of practice, but then it becomes very natural once you do a whole bunch of them. So in summary, morphine for most patients unless there's a contraindication. If someone has renal or hepatic impairment, I would think about hydromorphone, oxycodone, fentanyl, or methadone. I like to do IV PRNs every 1 hour for most people, and every 2 hours PRN if someone is very old, has kidney or liver issues. And when we want to maintain steady state in the setting of continuous pain, I'll do Q4 hours for immediate release, or Q6 hours if they have any of those issues, and then Q12 hours for most of the extended release medications. And we talked about PRNs being 10% of the total daily dose. So I want to talk a little bit about fentanyl patches. Are these something, I would imagine you see a lot of patients coming in on fentanyl patches. Has anyone seen an issue pop up with this recently? Yes. Yeah, tell me. I'm so glad you brought that up. So I was on call last weekend at BI, and I met this patient. And I'll just go through this very quickly. So Mr. O is 81 with CAD, CKD. He had 3 cardiac arrests during his hospitalization, and he's been in the ICU for over a month. He's had this horrendous course with bacteremia. He's been intubated 3 times. He now has pressure ulcers. He's been on and off of pressors. He has gangrene in both of his feet. So things are not going very well for him. I got called on Saturday morning because the family felt like he was dying. They made him DNR DNI. He had been extubated and was on high flow nasal cannula. And for some reason, he was on a capped dose of 15 micrograms of dopamine that he'd been on for 3 weeks. I don't know about that. The ICU had ordered fentanyl 175 microgram patch. They had been sort of up titrating for pain over the course of the past week. And I went to the ICU, and his daughter was at bedside and said that for the past 3 days, her dad had been really sleepy. He hadn't really woken up. He hadn't eaten anything. And she felt like he was dying and wanted hospice. So we transferred him down to the palliative care unit, assuming that we were doing comfort-focused end-of-life care. And on transfer, the nurses examined him and found that he had 275 micrograms of fentanyl on him rather than 175 micrograms. That was pretty concerning. So we did a MERS. We took all of the fentanyl patches off of him. And then it takes about 12 hours after you take off the patch for fentanyl to clear the body. So 12 hours later, we started him on a dilaudid drip based on the correct dose of 175 microgram patch. And the next morning, he was completely awake, and his wife brought him a donut that he ate, and it was on high flow, so it wasn't ideal, but he only aspirated a little bit. And then he was actually quite awake and quite happy for the next week, and he did end up dying in the unit, but he had a very good week. So the fentanyl patch the main one in the US is called Duragesic, and it used to be a gel reservoir, but there were a lot of problems with abuse of the patch. So they reformulated it into this drug inadhesive matrix a couple of years back. People are still abusing it, which I'll talk about. After you stick it, usually on the fatty part of your shoulder, a depot of fentanyl concentrates in your skin, and people see some effect by about 12 hours, and then peak effect by 20 to 72. And we'll usually dose it Q72 hours, but kind of like OxyContin, some people have end of dose failure early, and some people need to be on it every 48 hours. Some of the factors that increase absorption are having increased temperature and skin irritation. So if somebody is having continuous fevers, they may be getting a higher dose than you intend them to. And if fevers are going on for more than a day or two, that's a reason to stop the patch and convert to something else. And then some people consider cachexia to be a reason to not use the patch. But in practice, I find that it's often cachectic patients who are having a hard time swallowing who really can't take anything else. And often a fentanyl patch is the only way to get them home comfortably. So you just be mindful that absorption might not be what you're expecting it to be. And like I mentioned, after you take the patch off, it takes about 12 to 24 hours for the dose to be completely out of your system. So wait a bit before starting a replacement. This is a case report that I found in the literature of a woman who was wearing a fentanyl patch for pain and fell asleep on the beach in the south of France. Presumably had increased absorption in the setting of the increased heat, and 6 hours later woke up with really severe sunburns to the point that she had to be treated in a burn unit and given Narcan to reverse the fentanyl. So watch out for heat. And then people used to think that fentanyl was really abuse deterrent, but people are finding all these creative ways to abuse it. So there are a couple of case reports of people soaking patches in hot water and drinking the tea and needing Narcan and intubation. So this is one from Denmark, and then there was one out of NYU recently. And at our big conference last year, there was someone from the Midwest that said that people had been caught in a nursing home taking patches off of older residents, soaking them in hot water and drinking it. So people are creative. I just want to point out that Table 2 helps you convert from patches into another opioid. And in the interest of time, I'm going to skip the details. Who do you guys think of being good candidates for a fentanyl patch? Any patients that come to mind? Have you seen it be effective for people? Yeah, lots of cancer patients. Yeah, so it's great that you don't have to take PO. That's often really helpful. Anything else?
Sickle cell.
Sickle cell. So severe pain over time. Yeah, so people who have pretty stable, pretty severe pain, so people that need an opioid over a period of time without a lot of wild fluctuations, people with trouble with PO. It's especially helpful in head and neck cancers a lot of the time. People who can't really manage taking pills all the time. Ideally someone who can follow directions. I had a patient recently who was an internal medicine physician and was cutting his patches in half, but you really shouldn't tamper with the patch in any way. So sometimes you have to be very explicit with your directions. And ideally someone who is afebrile and staying out of the sun. So I just want to go through PCAs pretty briefly. And yeah, sure. No, that's a good question. I don't know for sure. I think as long as you're probably wearing clothes and in a ventilated area, it's probably okay. I don't know. I guess if you're cooking a whole lot in a very hot room, it could be affected. Oh, interesting. Like someone who's working as a cook or something like that. Oh, interesting. Thank you for mentioning that. PCAs, we see these all the time in the hospital, yes? I heard you guys just had a talk from Gina Simon not that long ago. Is that true? Sometime? A little while ago? Okay, so we'll briefly review PCAs. These are used in acute and chronic pain, very well studied in cancer pain. We use them all the time on 11 East and 11 Center, and now 10 Center. Patients love these because it helps them control their own pain, and they can titrate very rapidly to a safe and effective dose. Because of this built-in mechanism where sedation comes before respiratory depression in terms of opioid side effects. So if someone gives themselves too many PCA doses, they're going to fall asleep before they will make themselves unable to breathe. Some of the contraindications are being a very young child, some cognitive and physical impairment. So I'll sometimes use these for people who have very mild dementia but are able to be reminded how to use them. I had a patient over the weekend who was physically too weak to press the button. So that would be a reason to not use a PCA. Some people are reluctant to use them and just for whatever reason want the nurses to manage their pain. And then has anyone seen PCA by proxy or a family member sitting at the bedside pressing the button for them? So I'll usually start with educating the family member that that's not safe and we really can't do that, but that is a reason to sort of stop a PCA and use another method. In terms of the terminology, so when you see us write a PCA order, these are the parts of the order. The basal or continuous rate is the dose that's going in all the time without the patient or nurse needing to do anything. And not everyone gets a basal dose on their PCA. The bolus or demand is what the patient gives themselves when they press the button. The lockout interval is how many minutes have to pass before they can get another dose. So usually 10 or 15 minutes. And then the CAB or clinician activated bolus is a bigger dose that the nurse can give by putting a code in the machine. And I'll usually give that before the patient does a painful activity, like go down to radiation on a stretcher or PT. And has anyone seen this bad shorthand that we sometimes use in our notes? We're trying to move away from this because it's very confusing to everyone. But if you see something like this, what it means is this is a morphine PCA with a 2 milligram per hour continuous rate, 1 milligram Q10 minute patient bolus, and 4 milligrams Q1 hour clinician bolus. And these proportions are pretty standard. So usually the bolus, usually a continuous is twice the bolus, and the clinician bolus is twice the continuous. So it's a pretty standard way to write this. These are starting doses for PCAs in opioid naive patients. So 1 milligram of morphine as a demand dose is reasonable, 0.2 of dilaudid, or 20 micrograms of fentanyl. And in terms of transitioning off of a PCA, I'm sure everyone in the room knows this, but if someone's on a PCA and you want to send them home, please call us 24 hours in advance so that we can successfully transition them onto a long-acting regimen. And the way that I'll usually do this is start a long-acting PO regimen and stop the continuous rate right away. Or if we put a fentanyl patch on, it takes about 12 hours to start working. So I'll leave the continuous on for the first 24 hours. And who would we like to use PCAs in? Has anyone seen them be helpful in anyone recently? Sickle cell. What else? What? Post-op pain. Yeah, so the pain service writes them all the time as well. I like to use them in patients who have a new pain or changing pain needs. So for instance, someone with a new cancer with terrible pain who's down in the ER, and we really don't know what opioid dose they're going to need. It's a safe way to get to an effective dose. For patients who are struggling with loss of control in the hospital, so especially for bone marrow transplant patients who are usually really high functioning people who are here for months on end and have no control over anything, it can be very helpful to them to just have that button and be able to control something. And then I'll sometimes write them if a patient is stuck in the ER for days on end and they can't really access pain medications. And finally, I just want to talk about Naloxone. Has anybody seen these ads on the subway? So there's this ad campaign that the New York City Department of Health is doing, encouraging people to carry and administer Naloxone to people at risk of opioid overdose. And if we come back to our patient and she is unarousable, should we give her Naloxone? Basically, if she has depressed mental status and you really can't wake her up, despite shaking and yelling at her, and she's not really breathing, she's breathing less than 8 times a minute, with evidence of inadequate ventilation, like hypoxemia, those are reasons to try Naloxone. And if she were just unarousable but her breathing was fine, I would start by holding her opioid, but not giving Naloxone. If she's not breathing, then we'll stop her opioid, take an ampule of Naloxone and dilute it to 10 mLs, and administer that 1 ml at a time every 1 minute until she wakes up. Most people respond after 2 to 4 doses, and the response that you should see is deeper breathing and more arousal. And if you've given 2 whole ampules of Naloxone and the person has not woken up, it's probably not just opioid overdose. I've actually seen a couple patients in the past 3 weeks who were just in the normal dying process and were given Naloxone and didn't wake up from it, but we see that fairly often. Things that you probably know are that Naloxone lasts for about 30 to 60 minutes, whereas opioids, like I've mentioned, most of them last at least 4 hours. So you're probably going to have to give another dose or start a drip. And this may seem incredibly obvious, but you want to wait until their consciousness level is improved before restarting an opioid, presumably at a lower dose. If you look at nyc.gov, you can refer your patients to Naloxone trainings in the community, and they can get free Naloxone. These are the pharmacies in our neighborhood that carry it. And finally, has anyone else BLS recertified recently? I had to take it 2 weeks ago. It was painful. But they actually added giving Naloxone into the BLS algorithm, which I was really surprised by. So if you take your BLS card to a pharmacy, they will give you Naloxone, apparently. But if you suspect an opioid overdose, that's now in the BLS breakdown. So I'm going to stop. In terms of take-home points, let's use morphine for most of our patients and consider other opioids if their kidneys or livers are not working. The pain card that you now own is helpful for doing dose conversions. Go home and practice. I will start with short-acting medications, and if somebody is taking more than 4 doses a day, consider starting a long-acting medication. If you are using fentanyl patches, please avoid heat. And consider Naloxone if someone is unarousable and their respiratory rate is less than 8. And thank you so much.